Doctors Beggs and Parsons discuss the current status of gene therapies in rare neuromuscular disorders in this 8-part podcast series. This is derived from the symposium that was presented at the MDA 2025 conference in Dallas, Texas in March 2025 and is intended for healthcare professionals only. This podcast includes information about investigational compounds that do not yet have a regulatory approval or authorization for a specific indication. The safety and efficacy of the agents under investigation have not been established, and contents of this podcast shall not be used in any manner to directly or indirectly promote or sell the product for unapproved uses. The Aspiro clinical trial is on clinical hold since September 2021.
The views, thoughts, and opinions expressed in this presentation belong solely to the author and are subject to change without notice. The contents of this presentation do not constitute an endorsement of any product or indication by Astellas.
In this part, Dr. Parsons will discuss factors impacting safety and efficacy of AAV-mediated gene therapies.
The gene transfer trials for musculoskeletal disorders, if we look at musculoskeletal and neurologic disorders, we really do have the highest success rate in terms of treatment, but we also carry the highest incidence of treatment-emergent severe adverse events. And why is that true? Well, yesterday when we were hearing about Donovan as well, we sort of looked and said, when the first gene transfer therapies were started, he had a single muscle that was injected. When we look at Luxturna, we injected the retina. Now what is happening with these disorders is that we're giving these huge, massive doses of viral vector to patients. And so there haven't been a lot of gene transfer therapies that have reached the market, but you saw yesterday as well so many gene transfer therapies being worked on, but there are very few that have actually come to market. So there are a couple of reasons for that. One is with the indications that we have, we know that the musculoskeletal disorders are most likely to achieve benefit, but there are the high risk of severe adverse events. Route of administration, IV, for most of our disorders is the way we're going. We may end up having some intrathecal therapies as well that are coming on board, but right now it's IV, and that means, again, a huge dose of this viral vector and antigenic risk that is being administered. In the vector design now, we actually have more specific vectors as well as promoters that are being utilized to really target specific tissues so that we're able to focus in a little bit more on the tissues that we want to have affected. And then the dose, as I said, has gone from these little tiny local injections to really systemic, much broader. And now our patients are larger, so we're giving a viral genome per kilo dose that is just massive as we look at that. And then there really are challenges in terms of the translation of clinical trials to commercial treatment with these agents. And we don't always know, we're not always great when we do tests in clinical trials in small populations about when that's broadened to the commercial availability and we hit larger heterogeneous populations. So there are safety issues arising from these therapies, and I think that we have some experience now, certainly with the 3 diseases that I mentioned at the beginning, in terms of collecting some data and information to have a little bit more of an idea what to expect. Although, to me, the recurring theme is always expect the unexpected, because we still really are learning about this. So hepatotoxicity, we know that transaminitis is something that we see in almost every gene transfer therapy that has been delivered, and we have to watch really, really closely and follow our patients closely for this. We also have to select patients that we don't think have risk for additional liver injury or underlying liver pathology. Because as we found out in the X-linked MTM boys, we kind of missed that. Thrombotic microangiopathy. So we look at this disorder. We've had deaths in SMA from TMA. We have Duchenne patients that have had TMA. And this is scary because, as many of us as clinicians who have treated patients, you know that we end up getting thrombocytopenia. So is that it this time, or are they going to be fine? Are the platelets going to go back to normal? So I think this is another one that we have to watch really, really closely for. Cardiac toxicity. So we have had cardiomyositis, we've had deaths from cardiac toxicity. Again, something really, really important for us to think about. And in little kids, vomiting could be a sign of cardiac myositis. And for most of us who've treated patients with gene transfer therapy, what's one of the first issues that you get? You get nausea, vomiting, they don't feel good. So is that myocarditis, or is it just a standard side effect that we're seeing with treatment? And then, importantly, as we discovered, there actually can be an immune response to the transgene. It's not just the viral vector capsid, it's actually the transgene as well. And so that was discovered in patients who were treated for Duchenne. And so that's a really important thing in terms of looking now at what's our patient selection and how do we pick the right patients.
In the next part, Dr. Parsons will discuss understanding and preparing risk factors associated with AAV gene therapies.